Special thanks to His Excellency, Minister Budi Gunadi Sadikin, who's joined us from Indonesia. Distinguished guests, colleagues, and friends, thank you for joining us during a very busy World Health Assembly week. We appreciate your being here. My name is Riband. I'm Director of Access Accelerated, which is a unique collective effort of biopharmaceutical leaders who've joined forces to help countries address the large and growing burden of non-communicable diseases, NCDs. Specifically, we work with countries to help develop and implement health financing solutions that will benefit NCDs. And we all know we're talking about cancer, diabetes, cardiovascular disease, neurological conditions, mental health, lung diseases, et cetera. A very, very, very important problem we need to address. We're very proud to work in collaboration with partners, including the World Bank, Results for Development, AFIDEP, the Africa Institute for Development Policy, many other global and local partners, including PATH, the Coalition for Access to NCD Medicines Products, Novo Nordisk. These are our co-hosts today. On behalf of all of them, welcome to sunny Switzerland. We're already hearing this week about health financing as maybe the most pressing topic. Today, more than ever, health financing is critical to ensuring that people can get equitable access to quality care. So this is why we're here today. We know that external funding and overseas development assistance for health have become less reliable, less sustainable, and therefore new health financing approaches are essential. So we're here today to discuss practical ways to finance sustainable NCD responses in our rapidly changing world. We've brought together a mix of global and local stakeholders from various sectors to discuss practical solutions for optimizing how health resources are mobilized, pooled, and spent. All are important. And I really hope that today we can discuss what's possible. How can we open doors to collaboration that will make a difference going forward? So we're very honored to be joined by some outstanding speakers today, including Minister Budi, who will open our discussion and set the stage for what I hope will be a very robust exchange of views. But before we begin, I'd like to turn over to my colleague, Kim Green. She's the Global Program Director of Primary Healthcare for PATH and a key leader of the Coalition for Access to NCD Medicines and Products. Kim, please.
Thank you so much, Herb, and thank you so much to you and the team for organizing this with us. It's just been amazing. So, actually, my thanks goes to all of you because you have intrepidly managed the reign to make it here, and we're grateful. It means you are dedicated and passionate to NCD financing, and that's what we're here to talk about. We know that this year we have an instrumental moment, a critical moment with a high-level meeting for NCDs and mental health. How many of you have read the Zero Draft? So if you've read it, and even if you've not, you will know, or you will shortly know, that there are some pretty good targets that are there. It's not perfect, but there are some key targets, namely that at least 80% of countries need to have excise taxes in place. 80% of countries need to have at least 80% of WHO-endorsed products and medicines for NCDs available at no cost. And finally, that there needs to be no financial burden to access to NCD services, so 80% of countries at least. So those are great targets to see. But I think the key question is, and particularly in light of this year and what's happening with external financing for health through global donors, but also country-based budgets for health, is how do we finance these very important targets that are being put in place? So that takes us to today. We have brilliant minds here. We want to have a lively discussion on what we're learning from the FAN survey, so you'll hear about that very shortly, and what's been seen across countries where that survey was done, and key challenges, but importantly, key opportunities and innovation. Similarly, we'll be sharing preliminary results. We are implementing with the Coalition and PATH a survey across 15 countries in Asia, Africa, and Latin America, looking holistically at what's happening in health financing, what's happening in health financing and PHC with a spotlight on NCDs. So we have some preliminary data across 5 countries, and we'll be sharing some of the key results from that as well. But in addition, and as I mentioned, you'll be hearing from incredible minds across the World Bank, ministries of health, technical organizations, as well as the private sector. So, without any delay, I would like to invite the most esteemed, His Excellency, Budi Gunadi Sadikin, who is the Minister of Health for the Republic of Indonesia. Many of you will know Minister Budi. He was appointed as health minister at the height of the COVID-19 pandemic. And with that, he turned what was a complex challenge for most countries, including my own, to get vaccines to everyone. He did that in a matter of a very short matter of months. And with that, decided to tackle a number of other reforms that are very challenging, including for primary healthcare, digitalization, looking at how to increase access to production of vaccines in Indonesia. Indonesia is now one of the primary producers of vaccines for the world. So after tackling all of these challenges, he's now focusing on NCDs, and we welcome you to tell us more about how you're prioritizing NCDs in Indonesia. Welcome, Minister Budi.
So, good afternoon, ladies and gentlemen. This is my 5th year, so I will be 5 years in this job on the 23rd of December 2025. I'm a banker for 30 years. Zero knowledge about healthcare, and out of the blue, the president appointed me at the beginning of the rise of COVID in the 23rd of December 2020 to become the first Indonesian health ministers without healthcare background. So it is a very terrifying job for me as a banker. and after that, we had the G20 meeting in Italy on 2021, and I have to admit, this year, all of my friends are gone. The last one was U.S. Secretary Javier Becerra, which is now being replaced by the famous, I just met him a month ago in Washington, Robert Kennedy Jr. So all of these 20 health ministers are gone. So I feel I'm the oldest of the health ministers in CNC. But because of bankers, I would like to share with you some numbers. Indonesia healthcare spending every year is around 40 billion US. We have 280 million people. Average life is 72 years old. And then the average healthcare spending per capita is 140 US dollar. 140 US dollar. 60% of it come because of NCD. So 60% of the 40 billions is for NCDs. Bankers, I love numbers. So if I look the closest country, our neighbors, Malaysia, 76 years average life, 4 years older. And then they spend 430 US dollar per capita, 300 US more. So can you imagine, I just passed 60 last year. 60 Indonesia is categorized as elderly. The government give you a lot of things, freebies, discount here, discount there, for life license. It is good, but also very stigmatizing, because the government telling me that you are old man, So that's why I feel a little bit discouraged, and I decided to run my first marathon last year, and I passed the Berlin marathon. So I do hope that Indonesian life expectancy will go to Malaysia. 72 to 76. If in the next 5 years, Indonesian average life goes to Malaysia, logically, we will spend more. And if our healthcare system is efficient as Malaysia, we will increase 300 US from 130 to 430, like Malaysia. You multiply this 300 US with 280 million Indonesian, 84 billion US dollar additional funding. Double or triple the existing funding that I have. If I go to my next neighbor, the best, Singapore, one of the best in the world, 84 years average life, 3,300 per capita, 3,000 US more than Indonesia. If we go there in the next 10 to 15 years, 3,000 US more multiplied by 280 million, 840 billion US dollar additional money I have to spend. If I go to the most, whatever, greatest city, greatest country in the world, United States, 79 years average life, lower than Singapore. They spend 11,900 per capita per annum. 11,000 you multiply by 280 billion, it will be trillions of US dollar I have to spend. I will not have enough money. So that is the reason why when I study why Japan also 84, United States 79, Japanese only spend 5,000. Why South Korea 84 they spend only 4,000 and Singaporean? Because they do more on promotive and preventive rather than curative. They keep their people healthy, not to cure sick people. That's why when I check a G20 meeting, the title of the minister, Ministry of Health, and never found any country put the title Ministry of Sickness or Ministry of Curing or Ministry of Doctors. No, they always say Ministry of Health. So that's why this February, we embarked a very massive, ambitious plan to screen 280 million Indonesians annually. Started this year. With the help of World Bank financing, I am a money man. I successfully borrowed 4 billion US dollar from World Bank, ISDB, ADB, combined for 3 years, revamping 10,000 primary healthcare clinics that I have in 7,000 inhabited islands in the country. So we do massive screening for 280 million people. Starting 10th of February last year, yesterday the number is already reaching 6,000 and the daily run rate is 200,000 every day. So means about 5 to 6 million every month. If you said, Budi, that is fascinating, no, because during COVID, we can deliver jab to our people 2 million every day. So when Gavi is being given by the European or a US country a lot of vaccine that close to expiry date, give it to Seth Berkeley, they couldn't find expiry date to only 1 month. Or send it to me. How many million? 10 millions. I can do 2 million a day. So I will finish it in 5 days. So that's why our ambition is at least to be able to screen 500,000 to 750,000 Indonesian every day. So we will have the cohort of the data for our people. And you know what is fascinating for me? Blood tension. Hypertension is 30% of the 6 million that we are testing. Blood sugar, 15%. Cholesterol, 6%, 8%. For your information, number 1 death in Indonesia is stroke, 300,000 every year. Number 2, heart attack, 250,000 every year. Number 3, cancer, 234,000 every year. Number 4, kidney problem, around 150,000 every year. And Indonesian, when you hear the number, you multiply by 3. Because the way we are recording the data is very, funny. It's not totally reported like in developed country, like where do you live. So I always multiply by 3 based on my experience in COVID. So millions of people die because of NCD. And this NCD I learned, if you control your blood pressure below 120, 80, blood sugar below HbA1c 5.7, and also cholesterol, you will be okay. So after the screening, our plan is when you have above the limit, we will give a free medicine, the amlodipine, the metformin, or whatever it is, a statin, to control these indications, so then you get back to normal. Don't wait until you get sick later on because you have problem with your brain, with your heart, or your kidney. So that is what we have done to make sure that we can have a good control on our NCD. Of course, we are also preparing the hospitals. I just met with CEO Philips because he wants the World Bank contract, 400 cath labs that we will implement in the next 3 years. And we will also, the next bit will be 500 CT scans that we will implement. Because for your information, we have 38 provinces, 514 cities. We only have 40 cities when I joined that can do PCI interventions or thrombectomy when you got stroke. So can you imagine you get stroke in, yeah, in San Francisco, you have to bring it to Los Angeles because there is no machine in San Francisco. So that's what happening in Indonesian conditions. So that's why we are also revamping our hospital. So that is what we are doing. I do hope by the end of this year we can get the first cohort of our NCD population level databases, minimum 50 million. Next year we aim for 100 million. The year after 150 million, and hopefully we can get 250 million annual screening program for this 280 million Indonesians by 2029. And hopefully we can prevent the non-communicable diseases earlier because it was cheaper and also, better quality of life. So I would like to close my speech here. Indonesian population are young. So when I meet with Indonesian young people, they said, in today's economy, ministers, it's very difficult for us because we cannot afford to get sick, but we cannot afford also to get well because it's still so expensive. Now, I do hope with this new screening program, when I see them, they can say, Minister, it's easier now. We can access healthcare. We can stay healthy. And this is my wish, not just every young person in Indonesia, but for young people everywhere in the world to live a long, healthy, and high-quality life. So stay healthy and don't be sick. Thank you.
Thank you very much, Minister Budi, for sharing what's really incredible progress in Indonesia. It's extremely inspiring, I think, for other countries. I think it's clear that the world would benefit from having more finance people become ministers of health. So maybe this is a model that can proliferate. But speaking of finance and health, I'd like to introduce my colleague from the World Bank, Bruno Rivalan. He's the lead for partnerships in the Health, Nutrition, and Population Group of the World Bank Group. So Bruno, please.
Thank you, Herb. Let me first start by thanking Access Accelerator for convening us today. Minister Budi, thank you so much for your presence. You have the greetings from Juan Pablo Uribe, who cannot join us. And as we were preparing this morning for the day and looking at this event, we looked a bit at your background, Herb, and the impressive track record. And what does that come out of that background? It's a message of consistency. It's a message of persistence. And it's a message of deep and profound commitments. And I think it's those values that brings us today as we look at sustainable financing for the NCD response in a changing world. It's not an easy moment. Many disruption and change. You have mentioned some of it. But it's also a wake-up call, not to go back, but to accelerate. We're evaluating 25% cut across the board around development assistance for health. We're looking at decades of investments that have been driven by funding sources that was outside of the system of many countries. Not knowing how much was invested, with having most of the capacity and leadership that was outsourced. We're cost-benefit package. We are built around the funding outcome and not by the burden of disease. And where public and private sector entities were not speaking enough to each other or speaking the same language. So the response of today cannot be the ones of a decade ago, cannot be the one of a year ago, and cannot be the one of yesterday even. And when we look at our portfolio, when we look at our engagement as the World Bank Group, we try to take a step back and to say, okay, what is it that we're trying to do? We're trying to build a platform around people, designed to really support what matters the most for them. Going to school, working, raising children, caring for family, and living with dignity. And I think you've mentioned some of it, Minister Budi. With such platform, people can stay healthy without sacrificing hours for traveling or waiting in line. Families are protected for financial wounds because of illness, not having to choose between treatment, school fees, transportation, draining their savings, selling their assets, and pay for care. That's also why the World Bank Group is invested so much in the health sector. because it's an economic opportunity, because it can be an economic obstacle, and because it's a clear driver for jobs creation. And this platform doesn't just work in normal times. It adapts to crises like pandemics, floods. It ensures that people continue to receive the essential services they need, even during those shocks. And it's built around a strong primary healthcare platform as its foundation, supported by all parts of the government and supported by all parts of the society. So basically, it requires getting the fundamental rights, making them work in every context. Health facility needs to have the reliable electricity, the clean water, the sanitation, mobile or internet connectivity, access to diagnostic and medicine, not just in cities, but also in the last mile. Health workers are skilled, supported. Career development, growth is what incentivizes them, and they don't work in silos, but as teams. It's a system that looks ahead instead of waiting for people to get sick and show up at hospital. It acts early, screening for high blood pressure before it becomes a stroke, providing adolescent girls with HPV vaccine to prevent cervical cancer, managing diabetes proactively with affordable medicine to avoid kidney failure or dialysis. It supports people through every stage of their life, from newborn health to healthy aging. It meets them where they are. It raises money fairly, and it spends it efficiently and equitably. It ensures that the poor and the most vulnerable are protected through subsidies. And we expand also insurance while increasing efficiency through smarter purchasing and through reducing waste. It pools risk across population, young and old, healthy and sick, spreading cost fairly. And it is, most importantly, powered by data and trusted by people. Continuous learning, adapting based on changing needs and context. And again, I want to reinforce cost-benefit package that are based on disease burden and not by financing, external financing that is available. Why I'm saying all of this? Because this is exactly what is driving our commitment for health. As you know, last year, our president announced a target of reaching 1.5 billion with quality, affordable health services. Minister Budi, you were at a spring meeting event. As we were looking at our financing, Minister Budi said, well, that's actually 30% of your target in my country. So make sure the investments are driving there. And that's that outcome-driven approach that we want to really push forward, and the leadership, such as the one you are driving in your country, that we want to continue support. So how do we get there? It will take financing, I've mentioned. It will take integration. It will take leadership. And it will take shift, and it will take new partnership. And this is exactly what is behind our collaboration with Access Accelerator and the Financing Accelerator Network for NCD, the FAN, well known here, designed to work directly with governments and local stakeholders, offering both technical expertise and financial support to help build NCD financing system, policies, and programs. And I want to recognize here, Gina, the key role of R4D in setting up such innovative framework, and FIDEP also in launching the first regional one. So in closing, let me thank again Access Accelerator for this convening. You can count on the World Bank Group to continue working alongside, to listen, to improve, and very much look forward to hearing the solution. And again, this is both from our public financing arm, IDA and IBRD, but also as the IFC, and I have my colleague present here that can expand on that. So again, really looking forward to seeing how we can look at the solution and scale them up through country leadership and integration. Thank you.
Thank you, Bruno. It's wonderful to have the World Bank as a partner, and appreciate your being here today. With that, I'd like to introduce my colleague, Ruth Musila. She is with Takeda. She's the Multilateral Affairs Lead for the Global Health Group, and she is the Vice Chair of the Access Accelerated Executive Committee. So Ruth is going to lead us through a Q&A discussion. Ruth.
I think the elephant in the room, as we all know, and there are conversations ongoing in Geneva already about the withdrawal of overseas development assistance in many countries, and what this means as we discuss innovative financing for NCDs. So in this part of our session, we'd like to really get deeper into the conversation by talking about data and really data that informs homegrown solutions. So we're joined by the leads of two important studies that have been conducted by PATH and AFIDEP. And these studies are NCD financing studies across low and middle income countries that really will inform priorities and the shift of power and how countries can become empowered to eventually graduate from external funding. So we're joined by the leads of these studies. You've met Dr. Kimberly Green already. She's a global program director for primary healthcare at PATH. And we're also joined by Dr. Jackson Otieno, who's a senior policy analyst at the African Institute for Development Policy, or AFIDEP, which is also the financing accelerator network with Access Accelerated. So please join me up here. Oh, I'll sit here, that's okay. Oh, sorry. Shall I move this side? Okay, it's easier. Okay, so we'd like to talk about, so I'll first like us to talk about the leadership that we have seen and coordination of NCD financing in the studies that you've conducted. To both you, addressed to both you, Kim and Jackson. If you could tell us about this, as well as perhaps a part B to this question, what structural or political barriers do you see standing in the way of these successes? Please start. Feel free to start, Kim.
Okay.
Thank you.
Thank you so much for that question. And so just to provide some brief information, so the Coalition for Access to NCD Products and Medicines is a multi-sectoral group, and it includes members who are here in this room, including the Access Accelerator, the FAN, Novo Nordisk, and many others who are represented here. And our mandate is really to look at how best to partner with countries, industry, and others to ensure that the key products that need to be made available for NCDs are there where people need them. And so one of the key questions, the key question really that is a barrier or to access to essential medicines and products for NCDs is how to ensure that the money is there. And so we launched a study across 15 countries that balance countries across Africa, Asia, and Latin America, really trying to understand, number one, the allocation process for health financing in general, what the trends were over time, how much funding was going to primary health care and how much funding was going to NCDs. And so as part of this study, we did look at overall political leadership to answer that part of your question. And I think everywhere we saw that there was an NCD program. NCDs was represented in terms of long-term, mid-term, annual plans. So the overall, I think, political commitment reflected in key documents and policies were largely in place. However, when we looked at trends of financing over time outside of one country, and you may guess which country that is, so these are the 5 countries that we looked at. Only one country, and that country is represented here in this room, increased their overall financing for health. The rest decreased their financing for health between 2023 and 2024. And also in terms of the countries that we surveyed, 4 of them said that NCDs ranked around between a low and a middle priority for them against other health areas. But one country listed NCDs as their top priority. And again, I think you might be able to guess which country that was. So yes. It's outstanding to see the leadership that's increasing around NCDs, but clearly from what we found, and again, this is 5 of 15 countries, and these countries are not representative of all low and middle income countries, we didn't see as much commitment yet in terms of overall prioritization to NCDs as we would have hoped. So now, your second question related to structural barriers. Number one, none of these I think will be surprises. Number one, nearly every single country said they had challenges with forecasting the burden of disease, really having good surveillance in place, which then would enable a foundation for advocating for the right financing for NCD services. So that was a critical concern. The second concern had to do also with, and I think this relates to the prioritization right of NCDs, of healthcare workers at the primary healthcare level and community health workforce being adequately trained to be able to address essential NCDs. Third, we saw that there was a lack of a system of tracking expenditures, allocations and expenditures in general for primary health care, but specifically for NCDs, except for in one outlier country. And then there was the need for additional focus on prevention and promotion. So again, like as Minister Budi highlighted, the way that you reduce the cost to your pocketbook for NCDs is to invest in prevention and promotion. And again, we only saw one country that was prioritizing that sufficiently. So those were some of the key barriers that we identified. Thank you.
Thank you, Kim. Jackson, would you like to?
Yes, good afternoon. I believe it is afternoon now. I'm Jackson. I work with AFIDEP, that is African Institute for Development Policy, and together with our colleagues from R4D and with support from World Bank and AA, we have been able to do a more detailed study on sub-Saharan Africa NCD financing landscape. And our approach was to, first of all, look at the entire sub-Saharan Africa and try and see exactly what is happening in terms of financing NCDs. And looking at that, we narrowed across geographies and took the Western Hemisphere, where we have the Western African, then we took up the Eastern African, then the Southern African, trying to see some of the exemplar countries, what is it that they're doing that is so exceptional. And looking at that, it also gravitates around the issues of existing policies to facilitate investment in NCDs. So a number of countries, of course, and that is through governments and the ministries, you'd find that over and above having the health policy or the health strategy, you find that some of these countries have gone deep down to have a strategy around NCD. And some actually also have strategies that target disease-specific NCDs interventions. Then we talk about the whole aspects of ODA reducing, ODA donors walking out. But what is so big about that? Because looking at NCD as a component of ODA, it's just about 3% in Africa. And where does it go, even when it is 3%? You find that it goes towards very specific disease areas. So again, we went around and tried to understand within the resource mobilization scope, what is it that is happening? How much is government itself investing in NCDs? Of course, that is one of the structural challenges that are there. The issues around data. The key issue is that you will not be able to find a very good granular data around NCDs financing. Of course, you find, if you look at data, you find, for example, they're talking about 53% of the current health expenditure being directed to NCDs. But if you go in there, you find that much of that is out of pocket. Actually, of health interventions, one area that out of pocket is highly expended is NCDs. On average, it is 60% when you look at the African continent, but when you go specifically to some of the diseases, such as cardiovascular diseases, households spend up to 90% of their household incomes on NCDs. So we say that with NCD, you're just one step away from being finding yourself in poverty. So looking at issues around pooling, around national health insurance schemes, we find that even within the national health insurance schemes, NCDs are not well integrated there. And then that again falls onto the households. So I could go on and look at again, issues on how purchasing is done, looking at how they design the benefit packages. Of course, an element of, and I'm very glad the minister is saying that you're financing screening of over 200 people in your country. That is massive. In most African countries, screening is an independent cost. Actually, that is why we say, and I agree with you when you say curative preventive health. Our African continent, much of, if you go to their budgets, the program-based budgets, if you look at the program lines, Most of the money is going to curative, preventive investments. And if you look curative investment, if you look at the preventive, it is very little. And they have no problem with that, because the reason is that from a political point, you get more votes when a house stall is around you rather than investing in people. So I would finalize by saying that one of the structural challenges that we see from this study, and which is coming more and more, is the issue of data. And that data issue is coming on to the extent that you are in no position to go to the Ministry of Finance and say, this is the investment case for this disease. Can you put money into this as a great program? Thank you.
Thank you very much. So we've heard quite a bit, numbers of successes, but also barriers. Based on the studies that you conducted, I think it'd be really interesting to know if you were able to make any recommendations in terms of prioritizing any sort of reforms or investments. Is that something that you're able to speak to?
Yeah, so I mean, there was very rich data from the 5 countries that have responded thus far. And so one thing I just want to frame, which is interesting, is of the 5 countries, we asked if they had experienced any immediate impacts of the stop work order from the US government through USAID. And, you know, interestingly, so this was specifically on NCDs. I think if we asked them in general, they would have said yes, but on NCDs, interestingly, they said not right now. And I think that that's just speaks to the fact that USAID did not largely finance NCDs, right? So, but then there was that concern about the downstream, immediate downstream effects, which will occur on having to reallocate resources from health areas that were once financed through USAID. And to note, WHO just did a survey where they looked at the impacts of the stop work order on different aspects of healthcare in low and middle income countries. 25% of the countries that responded said that they had severe impacts on their access to NCD supplies and medicines. So just with that framing, then what's coming forward from our study? 100% of countries said they had health excise taxes in place. Not all of them for every single aspect. So all of them had them for tobacco. A few of them had them for alcohol and one for sugar. So there's room for improvement to further expand the excise taxes. One country said, though, that the money isn't going where it's supposed to be going. So again, thinking about the transparency of how those tax resources are used and how to track that is a critical recommendation that's coming out of this. Secondly, to the health benefits packages, there were many challenges that were raised, and Jackson has described them very eloquently. And so key recommendations coming forward would be to cover screening, to cover promotion and preventative services as well. Great example from Ghana, where they've done that, and obviously the example from Indonesia, but just to highlight another country that's really leading, they've expanded their benefits package to include health prevention and promotion, childhood cancers, end-stage kidney disease. So they're really going now that next step for greater coverage, which is so critical. Private sector. Private sector partnership is so important. Indonesia has done an amazing job of partnering with private sector for NCD services. And what I really appreciate is there's a great partnership, but also there's a focus on quality and price control to make sure that people don't pay too much or more than they should be out of pocket if that's what they're choosing to do. The other innovative financing or interesting financing that we saw were revolving funds and pharmacies in Kenya, 2 emergency chronic and critical illness funds that were set up, one in Ghana, one just last month in Kenya, which is really exciting to see. Vietnam has a tobacco control fund that's in place as well, which I think is really interesting. The birthday screening approach, which is highly innovative, and I think many countries will be looking at how to do that. But we didn't see any performance or results-based financing, which was interesting. But maybe we will see that from other countries. And then lastly, just to call out external donors, they still matter. They were still financing quite a number of donations of essential NCD medicines, and that every single country thought that that was important to continue. Thanks.
Yeah, I just pick from where she's left it, and I would globally say that from a macro perspective, Africa's economies are already facing multiplicity of issues. So saying that you tax them more is an overstatement, because already they are complaining about taxation. So all about what we need to appreciate as we speak now, the results of these studies show that, and you've put them very well, there are multiplicities of innovative financing ideas. So many that the government itself has not come around to appreciate. The policy that are currently there are not appreciating the onboarding of these innovations. She mentioned a few of them. Across Africa, if you go to Gabon, they have the social bond. If you come to most of the African countries, they have the social taxes. But if you ask someone from the Ministry of Finance and say, okay, let's ring fence the sin taxes, they really need some evidence to support the multiply effect of ring fencing some of those sin taxes. Then that brings me to the need to look at a way that we can onboard, African countries can onboard some of these very many innovative financing ideas that are already there. That alone would then call for the involvement of the private sector, the civil society organizations. Many of our international NGOs, many of our private companies have quite a bit of resources that if only, for example, there is the telephone, there's the telephone tax that some countries are using. There are other countries that are using the blending where the civil society organization or the NGO or whichever the private company brings on board so much construction to the primary health facility and asking the government to bring the medicine and bring the health force workers. So there's a lot that the government can do if only it promotes policies that bring on board the role of private sector. So having said that, of course, as I've mentioned on the issue of the evidence cases, the investment cases, I know UNDP is doing quite a bit in terms of investment cases, but not all in terms of NCDs. So those are just but a few that the government can do over and above what she just talked about.
Thank you, Excellency. So I think, Jackson, you've actually started speaking to the third and final question I had, which is about now that we've discussed these priorities, what support and coordination mechanisms would be helpful across sectors? You've already started talking about strategic partnerships and other actors, and perhaps, Kim, you could supplement what Jackson was talking about in terms of really translating these priorities into sustained, long-term, but also specifically country-led actions. It's okay.
I think just very briefly to say there's just an amazing opportunity coming out of the high-level meeting on NCDs and mental health for countries to come together around transparently reporting their allocations, their intended allocations for NCDs, how much is being spent, and including how much is being spent for health workforce, for medicines, and so forth, and then actual how much money actually does get spent in the end. I think that one key action and being able to coalesce across countries, and that could be led by a number of different entities. But that, I think, would be one of the single most critical steps that could come from the high-level meeting in terms of resource coordination. Thank you.
Thank you, Kim.
Two quick ones. One, as FUN, Financing Accelerator Model, we are providing about 3 issues, but I've already talked about one. So let me talk about the issue of cross-country learning. We need to provide African, sub-Saharan African countries with the opportunity to know who is doing what, how can we cross-develop issues that support all of us in terms of this field. The other thing that is key is the issue of financing. So I think this is where the catalytic seed funding comes about. Because some of these ideas that they have, it's just about a small investment to flip the needle. When we started talking with the sub-Saharan African groups, the country, we thought they would talk about very, 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 very significant issues. The country just said, all we want about this seed financing is to help us understand how much would it cost to finance NCD in this country, and that is all. doing a study to help them understand the landscape deeper.
Thank you so much. I'm afraid we've run out of time. But just to quickly summarize, I think it's quite clear that your studies are really just adding to the body of evidence that already exists, and a number of people in this room I know are working on as well and contributing to. Thank you so much for really highlighting for us that there are lots of innovative financing models, and that really strategic partnerships are the way forward to implement this, and together that we can actually address these issues. Thank you so much for your time.
Thank you, Ruth, Kim, and Jackson. Please have a look at the study for Africa that's been prepared, and keep your eye out for the NCD Coalition Path study coming this summer. With that, I'd like to introduce our next speaker. Gina Lago-Marcino is the president and CEO of our partner, Results for Development, R4D. Gina.
Thank you so much, Herb. It's so nice to be here. Thank you so much, Herb. It's great to be partnering with Access Accelerated. Results for Development, our mission is to support leaders in countries around the world to improve their health systems. And right now we are really leaning on our health financing expertise, given that external aid has dropped off significantly, and there's a huge need to support countries both to increase their own domestic financing and also use it better, but also integrate that better with the existing, the remaining external financing that's still coming through. So we're focused a lot on that, and that's why we're so delighted to be partnering with this group and in leading the FAN, the Financing Accelerator Network for NCDs, along with our partner AFIDEP, you just heard from Jackson, to really support countries on NCD financing. And I have the great pleasure today of facilitating a panel of country leaders who are really putting this into action. This is going to be very exciting. So I'm going to introduce that panel. Please come up as I introduce you. First, we have Dr. Belinda Nimako, who is from the Ministry of Health in Ghana, and she's the Acting Director of Policy, Planning, and Monitoring, and also the Evaluation Directorate. So please come on up when I introduce you. We also have Dr. Elizabeth Onyango, who is from the Ministry of Health of Kenya, and she is the head of Non-Communicable Disease Prevention and Control Division. Welcome, Elizabeth. And then last but not least, we have from MedAccess, Mayank Anand, who is the head of non-communicable diseases and maternal and newborn and child health at MedAccess. So good to have you all here. I'm going to move over a little bit so I can actually see you guys. This is quite a crowded room. And turn over my notes. So let's first start with Belinda. There's a lot going on in Ghana right now. You have a new president, President Mahama, and Ghana has been a leader on the continent of Africa in health systems design for years, with a national health insurance scheme that is a real envy of the continent, and also primary health care. And now you're focused on non-communicable diseases with this new initiative called, very well named, Mahama Cares. Can we start by just hearing a bit more about Mahama Cares and what that's all about and what it's going to do?
Sure, Gina, and good afternoon to everyone. I'm happy to join the panel, Gina. I think for us, the technocrats, even though the fund has been christened Mahama Cares, and just for context, Mahama is the name of the president. For us, the technocrats, we're pushing real hard to refocus on the proper name for the fund, which is Ghana Medical Care Trust Fund. And the reason is simple. We wanted to outlive the president. So for starters, it is interesting that it's called Mahama Cares because it's given it the traction it needs. Everybody wants to be aligned with the new president. But just to give that caveat that we are also interested in its reacquiring its proper name.
I know another little country that had a name for health reform that was after a president. Yes.
And everybody can guess where you come from. Anyway, so Mahama Cares primarily, I wish I would say, is an initiative that came from numbers. Because if you look at Ghana, 4 out of 10 of our deaths are NCDs. NCD caused. And so you would assume that given such a context, naturally NCDs will be prioritized. But Mahama Care did not actually come out of just the data. It was about the public, we have a high incidence of kidney disease. 13% of the country, that's the estimates. And if you look at the data, it's telling us that 1 out of 15 receive the care they need, mostly because we don't have dialysis centers, and even just the cost. Our average salary is about $200 per month for the average Ghanaian, and I'm not talking illiterates. These are people like me working in civil service. And yet, for you to have dialysis every session is close to $100, and you need multiple of that per week, minimum 2 or 3 for most people. So it's just that catastrophic expenditure. It pushes people out. So even for the few centers that they are, people are not able to access it. And now we have a huge incidence of illegal mining. So that is coming with more, increased cases of kidney diseases. So the former CEO of our leading teaching hospital is sitting here, Dr. Esechi. And what happened was that 2 years ago, they had to shut down the kidney center. They couldn't pay for the consumables. And when that happened, they have the kidney patients, they have a patient group. They got on the media. There was a whole fury. Everybody was upset because you're pushing people to death and you're looking on, and the dialysis center at our leading hospital is shut down. So the then government now decided to roll out a free dialysis program. But guess what? It could not be sustained because you haven't planned for it. You haven't ring-fenced the financing for it. And what that meant was we had this government initiative that did not outlive. Current president was in opposition, said, okay, when I'm in power, I'm going to roll out a fund for NCD care that will prioritize the kind of treatments that are outside the health insurance you've just mentioned, like the radiotherapy, the chemotherapy, and the cancers that are not catered for within the NHIS. And I'm going to roll out a program that would include dialysis. So really, in summary, Mahama Care was triggered by the fury in the country when that happens. And I'm emphasizing this because the work we do, whether for technocrats, those in CSO, or for researchers, ultimately what gets things done is the political will. And that political will does not come in a vacuum. It comes when the citizens ask for it. Because what the politicians care about is the numbers, is the votes they get. So that is, in the nutshell, how Mahama Care came to be, and the lessons that we can learn as we seek to advocate for ring-fence financing and everything that has to do with NCD financing.
Thank you so much. And I think we're going to see a lot more political calls for focus on NCDs in many other countries too. So I'm glad that Ghana is leading the way on that. Can we talk for a moment now, Belinda, about how you're actually operationalizing Mahama Care? I understand that you were appointed by the minister to a small 9-member panel that is tasked with actually getting this done. I imagine there's a few challenges and opportunities. Could you talk a little bit about that?
Oh my God. You don't want to know. It was a committee of Professor Emeritus, cardiologists, all the big names in the clinical world. And
that's why you're going to have to get all the work done.
It was fun. I think the biggest thing was to translate that vision into reality. So when we got into the meetings, is the design. Okay, we have this big vision, but resources finite. So it's clear we can't do everything. The first task was, what do we prioritize? There was a lot of debate. Is it all NCDs or we prioritize? So we were tactful. We've chosen language around cardiovascular diseases, diabetes, hypertension, cancers, and other NCDs. And that is to say, these are the priority because that's where the major disease burden is. So one, that prioritization within that group was essential. Two was to appreciate the limitations of a government committee, right? We needed numbers. We had to get our natural scientists to help us do the projections. And they were able to tell us, well, for what you want to do, you need X amount, 9 billion Ghana cedis, that's about almost $1 million per year annual to at least meet a minimum number of people. We also had to delineate within the continuum of care what sorts of services. So there was a lot of debate. Do you include prevention, promotive services, which has come up earlier this morning, or because the primary intention was to focus on catastrophic expenditure, do we limit it to, the high-level specialized care? At the end of the day, the decision that was taken is, yes, while the promise was about the catastrophic expenditure, and that's about the specialized care, the wise thing to do in a country where our STEP survey is telling us that 7 out of 10 people do not even know that they have an NCD until there's a complication, then it's important that within this funding, we make room for preventive services, the screening, as well as promotive services. So that was another bit of it that we had to take into consideration. The other thing was even the financing sources. And that was a lot of debate because, this is a resource-limited, country. There was a push for philanthropic organizations, donor partners, corporate Ghana to buy into it, which is ongoing. It's pretty interesting. The president has taken it on, personally, and they are contributing. But what we advocated for, which has now been packaged into a bill that's going to Parliament, is to seek for some statutory funds. So, for instance, now every year when you pay your car lines, we do annual renewals for our vehicle. 1% is to be deducted. The revenue from extractive industry, 1% is to be deducted to fund this, to support this fund. But what that means is we have to go back to Parliament to ensure that we get the legal framework to back some of these changes we want, and also to ring fence the funding that we want for the fund. So that bill is ready. And the last of it, Gina, if I may add, is the NHIS you mentioned. Now we're rolling out free primary healthcare, and the screening is supposed to be captured within that. All the preventive services is supposed to be in the free primary healthcare. But we are also asking for 10% of the national health insurance, because it does not make sense to have an insurance that only funds you, sickness. We want the insurance to also keep people healthy. So we've asked for that with the caveat that less than 10% of the funding of this fund, the funds available to the fund, we go into administrative courses, because we're also mindful that people can abuse it. And the final bit was to allow the fund not just to manage the fanciful things, but to be able to support workforce development, because you don't roll out dialysis without the physicians who can do that. It's also for it to support infrastructural development so we can have the dialysis centers. It's also to fund research, because we don't have experience with kidney transplant, but at some stage, some people, that fanciful care they need is the transplant. So the fund has made provisions for the system that will support NCD care, and that's how we've designed it.
Thank you so much, Belinda. That's really, really exciting. I think you've laid out all of the issues that countries have to go through in terms of figuring out what to prioritize and really how to get the money and then where to deploy that money. So we're going to be watching to see how this all happens. I'm going to move on now to Dr. Elizabeth. Kenya is also known as a leader on the continent for your health system and health financing on the other side of the continent. And I understand that you've just rolled out in 2023 a new Social Health Act, which has really shifted the health financing framework for the country. Can you please talk a little bit more about the Social Health Act and how, in particular, that is supporting more expansion of access to all kinds of prevention and curative care for NCDs?
Thank you very much. Thank you very much for that, and happy to be part of the panelists so that you can share with us the Kenyan experience. So in August 2022, we got a new government. And with a new government usually comes changes, shifts in policies as they implement their manifesto. So for the Kenya Kwanza government, they wanted to really reform on how healthcare is financed and delivered. And with a focus on shifting from predominantly curative to preventive and promotive, and relying more so on our own domestic resources because of the dwindling external funding. And there were talks about journey to self-reliance. So we wanted to walk the talk. So in 2023, within a span of 1 year, they were able to mobilize and have legislation put in place, and we enacted a law called the Social Health Insurance Act. And so with that, it established a social health authority, and the requirement is that every Kenyan must, or every resident, Kenyan resident must register with the Social Health Authority and be provided with the social health insurance fund number. And with this also came the establishment of 3 main funds. The primary healthcare fund, the social health insurance fund, and the last fund is, we call it the emergency, chronic, and critical illness fund. So the first fund, that is the primary healthcare fund, that's basically publicly funded through our taxes, and that provides access to preventive and promotive services at levels 2 to 3, that is the primary healthcare facilities. So even for NCDs can do the screening, the diagnostic, the simple diagnostics, and management, first-line management, counseling services. So there's a range of services that can be provided at that level. And as long as you have the insurance number, the fund number, then you can access those services free of charge. The shift for the social health insurance fund, that is provides, you can access services at level 4 to 6. Those are secondary to tertiary. And that is like an insurance. You have to contribute. If you're salaried, there's a proportion of your gross salary that is deducted directly, and it goes towards supporting that particular fund. If you're not salaried, there's a means testing that is used to determine how much you can contribute per month or annually. And for those who cannot afford, there's a mechanism by which the government is able to assess and identify them and pay for them. So the government contributes. Then the last fund, the emergency, chronic, and critical illness fund, this is a tax fund. It's also free to cater for emergencies. And if you exhaust your shift, if you go to the level 4 to 5, to 6, and you exhaust your cover, then you can be transitioned to this third fund, the emergency, chronic, and critical illness fund, which is a tax fund, and yes, you don't contribute towards it. So if I can just mention, to be able to manage this fund, there's the facility improvement and it's called Facility Improvement and Financing, is it? Yes. Act that was established, and this gives the facilities, the health facilities, the authority to be able to govern how they collect the money and how they use the money, yes, so that there's inbuilt accountability for the funds and they're not wasted. Yes.
That's fantastic. Can you say a little bit more about how this whole new infrastructure and architecture is really supporting NCDs and how you're able to finance and that kind of care? I'm really curious. Was there a new package of services with some additional services added to it?
What we have now, this is still at the formative stages, and we defined the package of interventions that can be delivered at level 2 and 3. Yes, it's not a whole range, and it's not really covering everyone because the funding is still limited, and there's opportunity maybe for people to contribute and support this fund. So for NCDs, simple screening for diabetes, hypertension, simple screening, simple diagnosis at that level. Then there's the defined essential package for pharmaceutical commodities, the kind of medicines that can be dispensed, prescribed and dispensed at those level is defined. And what happens at level 2 to 3, they use the capitation. So for each person, it's around 900 Kenya shillings. How much in dollars? Is it $6? Yes. So facility is gets a capitation of $6, $6 to $7 per person per year. So you can see it's still small, can't really cover everything, and considering it is free. But for facilities, recently we noticed there are changes because they're able to really mobilize a lot of funds. They're able to get reimbursement from the government, and they're able to improve their facility. That was not there before. There was no cost recovery initially for them. And so if they can see this money is retained for them to do, to improve the services, then they're motivated to provide the services.
That's very exciting. Sorry, didn't mean to interrupt. Did you have another point on that?
No, there's a lot we can talk about the shift. If you go to also the higher levels, how it works. Of course, there's a benefits package, a limit to how much you can access. If you exhaust your cover, then either if you have a chronic disease like NCD, you can easily be transitioned to this other fund, and you can access that.
Thank you. Thank you so much for that. Maybe just very quickly, I understand that you have some interesting collaborations with the private sector, and I'm curious if there are any public-private partnerships related to NCDs that you would have anything you'd like to share with this group about.
Yes, we have to agree that private sector, they play a big role in bridging the gap sometimes, and to complement also the government efforts. So for us, we have different types of private public partnership. We have the private that are for profit. We have the private that are non-profit, and we have the private for, I call them for small profit. Those ones, social enterprise, it's like they want to recover little so that they're able to sustain their social good for the community. And even among those private organization, we have those ones that are providers of services, the private facilities, hospitals, etc. Then we have those that are funding some of these health facilities. And what I can say, as a country, we have really benefited a lot from this private public partnership. We have the private institutions like the pharmaceuticals, etc., who have come in through access programs and supported the country, sometimes in providing free commodities. I can mention like insulin. We have the CDIC program. We have the Novo Nordisk that provide insulin for free. Roche comes in to provide is it glucometers for free, and the insulin, the glucose strips, etc. So, and then there are others who ensure that the medicines, they've reduced the price. And of course, with that comes the challenges because you're reducing the price, getting into the market. But the seller, the retailer, they determine how much they're going to sell it to the clients. So we can talk about that, the various foundations that have come in to build the capacity of healthcare providers to empower patients so they're able to take control of their own health. And those that have come in to support the supply chain, to provide digital solutions. And once you have like our country, we have, I mentioned yesterday, for those who are able to attend, the digital end-to-end solutions in terms of having the digital superhighway. And in that regard, of course, we have the private who are coming in to provide that infrastructure. We have a big telecom company, Safaricom, is supporting that. And what we want to have efficiency in the data, even with this, all the funds that we are coming to manage, we want to ensure that our patients, they have the unique identifier, so that when they go through the system, there is no duplication. Because without that digital, you find, Elizabeth, I go to maybe facility A. If it is not connected, if my information is not really connected to another facility, I might decide to go to another facility, and there's no record. Yes, we call them the phantom archives. Yeah? So you are like starting afresh, and I can get medicines from here. I can still go and get it from this other place. Yes, and to me, I don't believe that is good use of, efficient use of resources. So we just want one patient who is managed so well, and if is failing on treatment, not recovering, the system is able to pick up and communicate that. So just optimizing that, and that optimizing patient management for better outcome. And it's been enabled through that public-private partnership.
That's a fantastic example. Thank you so much, Elizabeth. That was very comprehensive on so many different levels, the financing element and then the delivery element. So we really appreciate that. I think there's going to be a lot to learn from both Ghana and Kenya on this. We have one more speaker I want to move on to. We're very delighted to have Mayank Anand from MedAccess, which has some really innovative financing programs going on. Maybe you can just start with giving us a little bit of a background on MedAccess briefly, and how the innovative financing facility works.
I guess maybe even before I introduce MedAccess, I think just to take a step back, we use innovative financing as a term quite frequently. But I think, what is innovative financing? There are a range of innovative financing tools available. The objective of an innovative financing tool is to help bridge the gap between traditionally available funding and the funding that's actually available. You may refer to it as advanced market commitments, to match funding, to development bonds, to guarantees. One of the objectives of using innovative financing tools is to actually absorb the risk that suppliers or procurers are experiencing when they're trying to either launch a new product in the market or trying to refer to newer ways of doing business or newer payment models. With that objective, MedAccess was formed in 2017 with an initial capital of $200 million from the British International Investments, which is UK's development finance institution, with the objective of deploying three main types of financial tools. One is called a volume guarantee. The second is procurement guarantees, and third are more frequently used as concession loans. Since the beginning, we've deployed a range of financing tools across TB, HIV, malaria. But what is really exciting is we've now started looking extensively into NCDs. And one of the recent deals we've closed is on how do you provide radiation therapy in a newer way. And hopefully we can speak a little more about that.
Yes, definitely. I understand that you have this groundbreaking new partnership with Electa, and it's, I guess, the first of its kind in Africa to work on a pay-per-use model. So can you tell us a little bit more about how that works?
Yeah, I guess, again, maybe to take a step back, but I think radiotherapy is really, really important. About 50 to 90% of cancer patients, unfortunately, would require radiation therapy at some stage of their treatment. We undertook a scoping effort with CHAI across 5 African countries, Kenya, Tanzania, Nigeria, Ethiopia, and South Africa to understand what is happening in the market. Why is it that radiation therapy is not as accessible? And we discovered there were three main barriers which were leading for poor uptake of radiation therapy. The first were a range of financial barriers. Buying a radiation therapy machine is extremely expensive. Each machine is going to cost a couple of $1 million. What is more expensive is actually sustaining the maintenance of the machine throughout the lifetime of the machine, which will again cost a lot of money. And the third challenge, which we actually saw, was the decentralized way in which procurement is happening. Even if the Central Ministry of Health were to buy an equipment, it is ultimately up to the hospital to maintain that machine, and that may not always happen. As a result of that, there are a lot of operational barriers. If the machine is there, but there is a frequent downtime because the supplier is unable to maintain it, you'll actually see the machine breaking down. And finally, although there are commercial models available in high-income countries where you would see either machines being leased out or machines actually being paid for every time a patient is being treated, which actually gets linked beautifully to national health insurance funds as well, because you can then attach a cost per patient. These were just unfortunately not available. So to address all of these barriers, we've created a pay-per-use model, which actually comes from lessons learned from a deal that MedAccess did with an American company called Hologic in 2018, where we helped in moving the market alongside a lot of partners towards viral load testing, in which the payment is made per patient as opposed to for the machine itself. Based on that, we've created a model which combines the machine, the service and maintenance, as well as the software, all bundled together into a single price per patient. On the back of this model, I guess the question then is, can the supplier actually offer something like this? What are the risks that the supplier would face in order to actually introduce a model like this? And that is where I guess the MedAccess financing tool comes in, where we've extended a guarantee at this point in time at the beginning to Elekta, which is a Swedish company, who are keen to launch this model to begin with in the East Africa region, where the objective would be if a machine is placed, then they would charge an upfront cost followed by payment per patient. And over a 6-year period, the cost would be recovered, and then the machine will passed back to the government. But I think one of the key aspect of this is if a certain number of patient volumes are not met, that is where a MedAccess guarantee would be used, where we provide sort of a shortfall payment on the number of patients that would be necessary. And overall, the payments would be linked to maintaining a minimum uptime of the machine, which helps in ensuring that everybody's working together in making the machine accessible.
That's very exciting. So this is a really innovative financing model to get cancer treatment to people on the African continent. And I'm curious, it sounds like you're just starting this now in East Africa. Are you seeing this as something that could be scalable across the continent? Maybe very briefly.
I guess 2 points or 2 considerations rather. I think the first consideration is the model is designed in a way that ultimately it has to be financed by the government, and the adoption has to be done by the government. So a model is great conceptually, but until it is actually adopted, you just need to put in a lot of effort. How do you think about insurance? How do you think about financing, getting the facilities ready, training of healthcare staff, etc.? So I think that is going to be a critical aspect and will also have to be considered for other markets. And secondly, I think we would want to see how it works in the East Africa region before it's scaled. Can it be scaled? Absolutely. We've seen it in other markets and other technologies work very well. So we'd be keen to see how it can be scaled to other markets as well.
Very exciting. Maybe you'll have make some relationships here, some opportunities in Kenya and Ghana. Thank our wonderful panelists. We really, really appreciate all of your points.
Thank you so much, Doctors Gina, Belinda, Elizabeth, and Mayank, for very concrete and very inspiring examples of ways in which financing NCDs can happen. So with that, and without further ado, I'd like to introduce Ora Vilhelmsen. She's the Global Health Equity Lead at Novo Nordisk and is also the Executive Committee Lead for Access Accelerated and on the Secretariat of the Coalition. Welcome.
So just a quick thank you again, but very importantly to all our speakers, moderators, and panelists, and to His Excellency Minister Budi, who could not be until the end, but it was so great to hear his interventions. And to my Access Accelerated members and partners, and to a big thank you to the Lean and Mean Machine, the Access Accelerated office, Herb and Tui, doing such a great job again, thank you. And of course to AFIDEP, R4D, World Bank, and PATH and the NCD Coalition. This is a very cozy session. I think we should continue that tradition and hope for really good weather next time. But I think we've had some good conversations, and I'm sorry we couldn't expand to to the questions, but hopefully we'll continue in the other meetings. So just wanted to reflect on something that was said in the closing session of the World Heart Summit. I don't know if some of you have participated. Richard Horton said with regards to the NCD high-level meeting and the process that we need solidarity, hope, and a plan. And I think really we've touched upon all three of those today. He also said that global health is a mess, but we're not going to focus on that right now. I really do think that these are essential pillars, and while we have been here to focus on the concrete plans, as the title of our session also says, from promise to practice, I also think that solidarity and hope are really vital. And we are living in a time marked by real setbacks, loss of funding, programs disrupted, progress undone. So it is imperative, this work that we do right now, showcasing the power of collective efforts. It was really well expressed by the ambassador of Luxembourg in New York 3 weeks ago at the multi-stakeholder meeting, where he said that it is critical that we use this opportunity to show that multilateralism can deliver, and it's not just an empty UN talk shop, as he put it. So really, we cannot miss this opportunity, because what's at stake is economic growth, stability, and human development. And addressing NCDs demands leadership beyond the health sector, and this is also what the Zero Draft Declaration calls for. So that's why I'm encouraged that we have here today colleagues from private finance, philanthropy, and policy institutions, because this can no longer be a conversation for health alone. We have seen also what the Draft Zero Declaration calls for as demonstrative successes in countries, and we have heard from our speakers today how resilience, boldness, and innovation indeed create those pathways for tangible success. In Indonesia, Ghana, Kenya, the work that MedAccess also does is a powerful example in the face of really complex challenges. So I'm very inspired and impressed. So we must continue to capture what's working, share lessons and apply them. And this is what the Access Accelerated does. We have talked a lot about, since last WHA and since New York, about how countries can achieve health financing sovereignty. Health taxes have had a really prominent role in those conversations, but it seems not to be a straightforward solution for the countries. And just to mention that at the same session on Sunday, Nick Banatlava said so well that it is important not only to have domestic resource mobilization, but well-targeted catalytic funding. And this is, again, a key role that Access Accelerated plays. Along with also from the Zero Draft Resolution, sorry, we're still looking at it and analyzing it and providing input, innovative financing mechanisms and partnerships, including with the private sector. So just to give a quick shout out to the FAN, the Financing Accelerated Network for NCDs, both FAN and FUN, which Access Accelerated launched as part of our technical partnership with the World Bank and in collaboration with Results for Development just last November. The AFIDEP is the first accelerated for the African region. We are planning on launching another one for the Latin America and the Caribbean at the end of this year, crossing fingers, and then the next one for Southeast Asia. The key role for the FAN is what Jackson was also saying, facilitate cross-country learning. So these are not north-south solutions, but really region-based ones. On-demand technical support to governments and stakeholders, and catalytic funding. And as Jackson also so well put it, a small but critical investment to flip the needle. So just in conclusion, besides the solidarity, hope, and plan, I think from today my 3 key takeaways are partnerships, financial mechanisms, and homegrown practical solutions. The high-level meeting on NCDs later this year will be a major milestone to set the tone for the next chapter, but what we do now and here and beyond matter at least just as much. So last shout out to the NCD Coalition meet and greet later today at 3:30. You are invited if you have time. And also please join us in supporting the Financing Accelerated Network in the countries and at the region level and with your stakeholders. Thank you so much.